Hi, good evening, everyone. Sorry for last week's delay.
Screens are
Multiple,
there.
sorry, multiple family members were down with influenza, so I had a tough time. Now things are better. There's a big breakout of influenza in Bangalore, H1N1. So luckily, I had taken the vaccine, so I myself didn't get it. But anyway, going on to discussing about today's topic, it's important. It's diabetes mellitus. No, that's a bigger outbreak. That's a pandemic, right? So we have this non-communicable disease pandemic, amongst which diabetes is right up there, along with all the other components of metabolic syndrome and, and obesity. So without further delay, what is diabetes? Basically, diabetes is increased blood glucose, right? So when there is hyperglycemia, the when there is hyperglycemia, we deem the particular person to have diabetes mellitus. So it should be consistent. So not a single reading. A single reading need not indicate that the patient has diabetes mellitus. This I'm talking about blood glucose levels. Okay, so there are different ways to diagnose diabetes and monitor diabetes. So amongst which blood glucose is the most commonly used method. And if you check the blood glucose levels for a particular person, and if it happens to be elevated means what? We should know what is normal. So what is normal blood glucose? Normal blood glucose is if we measure in the fasting state, blood glucose level, fasting blood glucose or sugar level should be less than 100 normally for a normal individual. Whereas if you challenge the person to consume 75 grams of glucose and check for their blood glucose levels after 2 hours of that 75 grams of glucose. So post 75-gram glucose, 2 hour postprandial sugar level should be less than 140. This is normal. This is what we consider as normal. If it is now between 100 to 125, we call it as impaired fasting glucose. Okay, or impaired glucose tolerance, the component of impaired glucose tolerance. Likewise, if the postprandial is between 140 to 199, actually 199, then again it is a impaired glucose tolerance. This is basically pre-diabetes. Person is not yet a diabetic, but this is pre-diabetes. How did we arrive at these values? It was through studies which showed that when the values of glucose are exceeding these, then the person goes on to develop complications of diabetes. So that is why we are mainly worried about secondary prevention, right? From your community medicine days, primordial prevention is trying to instill good lifestyle habits and measures to prevent the disease in the first place. Primary prevention would be to try and, if you catch them at this stage, you can try and prevent diabetes from happening by, again, through active lifestyle measures. Secondary prevention is a person has got the disease, but at least let's prevent the complications of that disease. So it was noticed through studies that if the levels exceeded these, when the fasting is consistently above 125, that means 126 and beyond milligram per deciliter, or if the postprandial 2 hours after 75-gram glucose, if it is more than 200 or more, then such individuals went on to develop complications of diabetes. That is why these values were arrived at. Okay, so which means anytime that the fasting is greater than 126 or 2 hours 75-gram glucose, post 75-gram glucose, anhydrous glucose, okay? If this value of sugar is blood glucose is more than 200 or more, then it can be considered as diabetes mellitus. So this is abnormal. This If these values are exceeded, these patients will go on to develop complications, the retinopathy, microvascular and macrovascular complications. What was studied was retinopathy. Okay, in the trials, no initial studies, that is what was mainly focused on retinopathy. What glucose levels, if they were followed up, at what levels did individuals develop retinopathy. So based on that, the abnormal and the intermediate, that means the pre-diabetic stage values were arrived at. Okay, I'm sorry. Yeah. So these are the normal blood glucose and the abnormal blood glucose values. Now, you know that we don't only rely on blood glucose levels directly. We also rely on HbA1c, and that is glycated hemoglobin, also previously known as glycosylated hemoglobin. Glycated hemoglobin is actually an advanced glycation end product. It's an AGE, advanced glycation end product. That means we have this hemoglobin inside our RBCs. It's a protein. So these proteins end up getting attached to blood glucose or glucose in general. But blood glucose goes and attaches to these proteins, and in a non-enzymatic manner, they end up becoming glycated. These are known as advanced glycation end products. HbA1c is the hemoglobin that is getting glycated. So you can measure this and get an idea of the person's last 3 to 4 months. Okay, generally we take it as 3 months, but you know that RBCs, if there is an RBC, it will have hemoglobin and it should live for an average of 120 days, which is technically 4 months. But what has been noticed is hemoglobin, HbA1c. This has hemoglobin. When the glucose comes and attaches to it, it becomes HbA1c. So this HbA1c, when you measure out of the total hemoglobin, suppose there are 100, let me put it as 100 grams of hemoglobin in the blood. Out of this, some 6 grams is glycosylated. So it becomes HbA1c. If it is 6 grams is glycosylated, the rest 94 grams is not glycosylated. So it becomes 6 divided by 100 at 6% of the total hemoglobin that is glycosylated or glycated. So this is the percentage of the total hemoglobin that is glycated will be known as HbA1c or glycated hemoglobin. This will indicate the person's last 3 months blood glucose level. So it is proportional to how high was the blood glucose level. The higher it is, the more the HbA1c percentage, the more percentage out of total hemoglobin that will get glycated. So keep this in mind. HbA1c is a percentage. It's not an absolute value. So it will get affected by hemoglobin. Anytime you are looking at HbA1c, please check the hemoglobin value also. Lot of times, what will happen? 40-year-old lady will present, and obviously being a 40-year-old lady in India, iron levels will be low, they'll have anemia. So hemoglobin may itself be 8 or 9 gram per deciliter. And then you'll interpret the HbA1c. You may not be interpreting it correctly. It may not be reflective of the last 3 months blood glucose levels because it's a percentage. It's a proportion of total hemoglobin that has been glycated. Okay, so keep an eye on the hemoglobin also. Don't only rely on the HbA1c before you interpret it. Okay, if there is any doubt, don't look at the HbA1c, look at the fasting and postprandial. There's a reason why HbA1c was developed. We'll discuss that a little later. Okay, so these are the normal and elevated values for blood glucose. So any disorder which has persistent and consistently elevated blood glucose levels will be known as diabetes mellitus. Remember, we have diabetes insipidus also. Diabetes refers to the increased urine output, which happens because of osmotic diuresis. Glucose has osmotic property. It will attract water towards it. So the higher the glucose in the blood, the higher filtration that happens to the kidneys into the urine, the more water gets dragged from inside the body intravascular into the urine. Therefore, osmotic diuresis. Mellitus means sweet. So sweet urine. Okay, so years ago, Charaka had discovered that people who had diabetes had sweet urine, and that is why ants were attracted to those people's urine. That's how diabetes mellitus has been even described in our ancient history. Okay, diabetes insipidus is incessant urine. That is because of the hypoosmotic. That is because of ADH deficiency. So diabetes mellitus is osmotic diuresis. In diabetes insipidus, there is hypoosmotic diuresis. There's dilute urine. Okay, so keep in mind any disorder with consistent high blood glucose levels. This is what is normal, and that is what is high. Okay. Yeah. So HbA1c value, what is high? HbA1c value below 5.6%. Okay, is normal. It's normal. Between 5.7 to 6.4%. Okay, these are percent. Please keep in mind. Please make sure that the hemoglobin is not affected. If there is anemia, you're in, or for that matter, if there is polycythemia also, if there is erythrocytosis also, because whatever studies were done in people with normal hemoglobin. If the hemoglobin is very low or low in at all, or if it is very high, rarely very high, then also the interpretation will get affected basically. So 6.4% will be impaired glucose tolerance. Anything above 6.5% will be diabetes mellitus. That clear? 6.5% and above will be considered as diabetes mellitus. If so, in this case, one single value is enough. You need not have to look for consistent hyperglycemia, because if you get this kind of a value, you better repeat it. So at least a 2 week gap, you leave and you repeat. Suppose, not this, I'm sorry. If this kind of value, if you get, suppose you tested the fasting blood glucose level. Fasting means what? They should not have eaten anything for 8 hours. Okay, 8 hours, no calorie intake, no food intake, no sugar intake. Okay, no tea, no coffee, nothing. So 8 hours of NPO, nil per oral status, water is fine. After that, check the fasting. After that, check the blood glucose level. If that is 126 or beyond, repeat, because one single value, however good a lab is, can be erroneous. So please repeat. If you are able to demonstrate consistent hyperglycemia, then you can label the person to have diabetes mellitus. Okay, likewise, a 75 gram, we generally don't do this 75 gram blood glucose. Actually, HbA1c is now the preferred, including American Diabetes Association. Now, since 2024, they have placed HbA1c as the method of, or ideal, what do you say, most recommended method of diagnosing diabetes over and above the fasting. Okay. There is a third way to diagnose apart from fasting and HbA1c, that is random blood glucose. Randomly, you check the blood glucose, and if it is above 200 and the person has symptoms consistent with symptoms of diabetes mellitus, then you can make a diagnosis of diabetes. Okay. So this is one. This is 75 gram glucose. We don't do very often now. This is two. In fact, this is more preferred. Maybe I should put this as one. Let me do that. I'll keep this as one, the most preferred, most recommended method. This is two. And third one is if the RBS, random blood glucose, or random blood sugar, is 200 or more plus symptoms. Symptoms of diabetes. What symptoms? Everybody knows diabetes, right? So sugar is osmotic. The more the sugar in the blood, the more it will attract water as it goes out through the urine. Is going to be glycosuria. With glycosuria, osmotic diuresis, there's going to be polyuria. So a lot of urine being passed. So polyuria, which is osmotic, and as a result, they'll be very thirsty. So polydipsia, more water to be drunk. And the sugar is not entering the cells. Okay, all the sugar is going out. It's in the blood. It's not going into the cells. It's going into the urine, but not going inside the cells. So cells are hungry. The cells are not getting what they want. They're not getting their glucose, their quota of glucose. So the person's appetite will be stimulated. So the person will be eating more. So polyphagia, polydipsia, polyuria, weight loss. Okay, significant weight loss is also a feature of diabetes mellitus, hyperglycemia. And then any of the typical complications. Unfortunately, that is the problem. No, in diabetes mellitus, these symptoms are not common. It's a very small percentage of patients who will experience these symptoms and then seek medical attention, then get themselves tested, get their sugar test done. A vast majority, more than 50% of individuals will not have typical symptoms. And that is why they will not be aware that they have diabetes. So the diagnosis gets delayed. Most often, the symptom of diabetes that they experience is not because of the high sugar, it's because of the complications that they have developed because of years together of high sugars. So it might be microvascular, might be macrovascular also. That is why screening is recommended. Okay, so screening of diabetes mellitus is recommended. It's a pandemic everywhere, every country. Okay, it's a lifestyle disorder, right? Everybody knows it's because of faulty lifestyle. For millennia, we knew at least what we think, what we are confident about is that Indian civilization knew what is the correct lifestyle, what is to be done, what is not to be done. But now we are in an age where food is easily available and work is you don't have to work hard. You can sit and you can get most of your work done. Okay, even that food will come home to you easily. So basically, calorie expenditure has gone down. It's all a balance. Okay, calories. What is the intake versus what is the expenditure? Are you expending your calories? How? Are you working out? You need not have to do intense workout, but are you spending the calories that you're taking in? That much you have to see. If you're maintaining your calorie balance, if your intake is close to your expenditure, then your lifestyle is adequate. It is healthy. Okay. If your intake is more, which tends to happen these days, calorie rich food, okay, high sugar, high oil, everything is fried, and so easy to order from outside. So intake of calories is gone up, expenditure has gone down. So the body is filled with calories. What does the body do? It will end up converting those calories into glucose, into cholesterol, into uric acid, into blood pressure, into fatty liver, into polycystic ovarian disease, into aortic stenosis, into non-alcoholics, steatohepatitic, what is now called as metabolic dysfunction associated steatohepatitic liver disease, MASLD. Okay, so all these are features of metabolic syndrome, also known as syndrome X. Syndrome X, right? So that's what diabetes is a component of that. This is I'm talking about type 2 diabetes, okay? Type 2 diabetes. We'll come to what are the types of diabetes, but type 2 diabetes is a component of lifestyle. That's the overwhelmingly most common type of diabetes. There are several other types, but they get masked by type 2 diabetes. In all likelihood, it may so be happening that patient has some other type of diabetes. Maybe they have diabetes because of pancreatic disorder, or they have diabetes because of some syndrome, or maybe it's a genetic or a monogenic diabetes, MODY. They might have MODY only. Okay, but on top of all this, because of the lifestyle choices or otherwise, maybe not the right thing to say choices. A lot of times it's imposed on you, right? Anyway, but because of this lifestyle, they'll end up developing type 2 diabetes, which is why we never end up diagnosing the other type of diabetes. Overwhelmingly, what we come across is type 2 diabetes. So that is important. So screening is advised for general population screening from the age of 35 years. So anyone who is more 35 years or above should undergo a screening for type 2 diabetes mellitus. So you test for it, do your FBS, do your HbA1c, do your RBS if you're symptomatic. So screening will not imply, I mean, screening will not apply to symptomatic. Symptomatic is they are actually undergoing testing because they are having symptoms. Screening is without symptoms. You have to test. So if a person is 35 or above, then they should, even if they don't have symptoms, they should undergo testing. And that is what is screening for diabetes. If the person is diagnosed, then you have to manage accordingly. If the person is not having diabetes, then you can do it once in 3 years after that. So once in 3 years. And by the time they are 45 and above, better to do it yearly. Okay, 45 and above, better to do it yearly. Screening asymptomatic patients. That is what is recommended by ADA. 35 is the cutoff. Okay. This is unlike any other endocrine disorder, no? Except maybe hypothyroidism. Hypothyroidism also screening is recommended, but that is generally after the age of 60. So hypothyroidism screening you can do after 60. But diabetes, 35 years. This is even when there is no suspicion. Okay, most other endocrine disorders, whether it is Cushing's, whether it is pheochromocytoma, whatever it is, most other endocrine disorders, you will you will screen when there is a suspicion, meaning they have some symptoms, some manifestation. Only then you'll screen. Whereas for diabetes, it's so rampant that general population has been recommended to be screened beyond the age of 35 and above. Okay, so yeah, that's about what diabetes mellitus is. It is characterized by consistent hyperglycemia. There are different types, but what is most common is type 2 diabetes, which is a lifestyle or non-communicable disease. It's a non-communicable disease, correct? Mm, yeah. So what are the types of diabetes mellitus? I'm sorry, this page need not have been there. Yeah. So what are the types of diabetes mellitus? Type 1. What is type 1 diabetes? It's uncommon. Uncommon, but what is it? This is a type of autoimmune disease. This is an autoimmune disease. Okay. And what we use for diagnosis, what helps in diagnosing it is autoantibodies. But autoantibodies are not responsible for the actual disease. So like we discussed about hypothyroidism, no? In hypothyroidism, Hashimoto's anti-TPO is not responsible for the actual manifestations, but you can use it for diagnosis. Unlike the thyroid TSH receptor antibody, this TRAB you can use for diagnosis also, and it is responsible for the manifestation also. So in Graves disease, in Graves disease, the TRAB antibody is actually responsible for the pathogenesis and can be used for diagnosis. But anti-TPO in Hashimoto's, it is not responsible for the actual manifestation, but you can use it for diagnosis. Likewise, in type 1 diabetes, there are autoantibodies which are not directly responsible for the destruction of the islet cells. Though there are some antibodies which are named like that, anti-islet cell antibody. There are antibodies like that, anti-islet cell antibodies. But it is not the actual main reason for the destruction of the islet cells or the of Langerhans. Instead, it is cell mediated. It is mainly a cell mediated autoimmunity. Majority is the cell mediated autoimmune destruction. Okay, so but as a side profile or as a side consequence, we end up getting autoantibodies, and we use those for making a diagnosis of type 1 diabetes. So GAD65 is the most recommended autoantibody for diagnosis of type 1 diabetes. Okay, but remember, it's not responsible. If you took this GAD65 autoantibody and put it into an animal or a mouse or a experimental model, you wouldn't replicate type 1 diabetes. You will, because it's a cell-mediated disease and not a autoantibody-mediated disease. Okay, there are zinc transporter 8 autoantibody. Then there is insulin antibody also, insulin autoantibody, IA2. So all these are different autoantibodies that you may come across in type 1 diabetes. What is the relevance? Useful for diagnosis. In fact, for staging also. So there are stages of type 1 diabetes. There are actually four stages, but the fourth stage is just complication. So what are the three stages of diabetes, type 1 diabetes? Okay, this applies for type 1 diabetes. Stage 1 is when they have two or more actually in every stage they have two or more autoantibodies. This is common to all stages. But along with that, their blood glucose is still normal. They're not elevated. So normal blood glucose is normal. Whereas in stage 2 of type 1 diabetes, the autoantibodies are present, but the blood glucose is elevated but not abnormal. That means it's in that impaired glucose tolerance range. So pre-diabetes range. So dysglycemia, not yet abnormal, and elevated blood glucose or abnormal blood glucose is considered stage 3. That means they have symptoms, which means they have symptoms. So patients of type 1 diabetes, the moment they have symptoms, they're in stage 3 of the disease, third stage of the disease. Stage 4 is when they develop complications of long-standing hyperglycemia. Okay, so these three stages you need to, you can remember the fourth stage also, it's complications. But these three stages of, for sure, you should remember. Very important because we have a drug now which we can use in stage 2 to prevent the person from going into stage 3. So what might happen? A young person is undergoing screening test, and maybe they're trying to join a university, and the university mandates blood glucose testing, and you check the tests and it is impaired, in the impaired range. You didn't expect it. Maybe it's the person is physically active, appearing physically fit, also healthy lifestyle also, and yet during a routine test their blood glucose profile shows that it is not normal, not yet diabetes but not normal, it's in between. And then you are now suspecting whether the person has type 1 diabetes, and you do an autoantibody profile and you get at least 2 positive. You get GAD65 positive, anti-islet cell antibody 512 positive. So now the person will be deemed to have type 1 diabetes stage 2. So in order to try and delay this individual from going into stage 3, now there is a medication, and that is known as, anybody? Anybody? This is maybe slightly higher point. Anybody who knows which is the drug which can be used in type 1 diabetes stage 2 to prevent them from going into stage 3? The clue I'll give is, it's not a great clue, but it is anti-CD3, anti-cluster of differentiation 3. Okay. This is a tough one, so no problem if you have not heard of it. It's teplizumab. Teplizumab. So if you're asked, no, if you're ever wondering in type 1 diabetes, apart from insulin, are there any other drugs that are useful? Yes, there are a total of 4 medications that you can use in type 1 diabetes, including insulin. So insulin is obviously, earlier, what was type 1 diabetes known as? It was known as insulin deficient diabetes. So we don't use this term, insulin deficient diabetes mellitus, IDDM. Why it was used? Because mainly the islet cells, that means the beta cells of islet of Langerhans, was getting destroyed because of autoimmune process. Therefore, the person landed with insulin deficiency and eventually diabetes mellitus. So that is why the term insulin deficiency was used. So basically, you need to give insulin. Otherwise, it was fatal. Before the discovery of insulin, type 1 diabetes was fatal. Once insulin was discovered and started using, then patients with type 1 diabetes started surviving. So there might have been a time where type 1 diabetes was more common than type 2. Now, no competition. It's hands down type 2 diabetes, which is more common. So teplizumab is the other type of drug which can be used in type 1 diabetes. There are 2 more. I'll tell you later. Okay. So this is the importance of staging diabetes, stage 2. You can actually use a particular drug to try and prevent them from going into stage 3. Prevent meaning delay. Okay. We don't have data yet whether it can totally prevent. Still follow-up studies are going on, so time will tell us. But at least it will delay the onset of hyperglycemia. That means onset of diabetic range blood glucose levels. Okay. So remember, when you're talking about type 1 diabetes, in type 1 diabetes, let us say this is a graph which is depicting time and maybe beta cell reserve in the islets of pancreas. So initially there'll be a, yeah, let me just show how the decline in beta cells may be happening. Okay, this is the way beta cells decline because of autoimmune process, mainly cell mediated. Some autoantibodies are also produced. But the point at which the diagnosis of diabetes is made is probably here. When more than 80% of beta cells have been destroyed, that is when the person actually ends up developing diabetes mellitus. So there's a big lag. So they'll have autoantibodies present at this stage itself. This will be normal beta cell reserve. They'll have autoantibodies present. And that means it is indicating that the person has an autoimmune process, probably affecting the pancreas and causing cell-mediated destruction of the beta cells. Yet the insulin production may be coming down, but it's not enough to produce diabetes until 80% of the beta cell reserve is totally lost. Only 20% is surviving, then they'll develop symptoms. Okay, then they'll actually enter into stage 3 diabetes mellitus. Okay, so there's a lag, big lag. So if you can catch them somewhere here, somehow if you catch them during a routine test, somehow it was picked up, then you can offer teplizumab. Okay, so this is type 1 diabetes. The thing about type 1 diabetes is it's not going to be associated, it has insulin deficiency. It will not be associated with the metabolic syndrome features. They'll not have hypertension, they'll not have dyslipidemia. You don't expect it. And it tends to occur at a younger age, though we can get later presentations, but most often the patients will be younger in age. Okay, all this is getting challenged. Day by day, we are seeing older patients with type 1 diabetes and younger patients with type 2 diabetes. Everything is getting challenged because of the rapid advances. Just think about it. Think about, let's say, your grandfather. When he was your age, when he was in his 20, your grandfather, how was his lifestyle? How, what was it that he ate? What kind of food? How did he, and what kind of work did he do? So compare that with your father. Okay, at age of 20 or in their 20s, what was their lifestyle? If you notice, it will not be too different between your grandfather's lifestyle in their 20s and your father's lifestyle in their 20s. Not so much of a difference. Compare it with your own selves. Okay, maybe you guys are doing well, but then compare with your generation. Okay, the others around you who are 20s, maybe not medicos also. Look, think about the non-medicos. So it's vastly different generations. Okay, a lot of generations skipped. So what we generally expect, the diseases which we should have been expecting in 30s, 40s, now we are seeing in teenagers. So that's the kind of speed with which lifestyle related disorders are tending to come early. So you have to keep in mind, okay, the old thoughts that okay, screening of diabetes should begin at 35 now. It used to be 45, now it's become 35. Probably in the next 5 years, it'll become 25. The way things are going, right? So anyway, uh, health education, totally missing. Lifestyle, whenever I talk about lifestyle disorders, I always go towards health education. Is the general public aware of what is healthy, what is not healthy? No, not aware. And that is where we should be focusing. Instead of doing long sessions on how to control blood glucose levels once it has crossed the normal limits, the entire focus should be on preventing. These are preventable disorders. Okay, we didn't have it for millennia. Diabetes, type 2 diabetes mellitus, it was unheard of. Okay, maybe just the royals might have had it who were in excess calorie state, but the common man never had it. And now things have reversed. Anyway, so type 2 diabetes is exactly that. It's a non-communicable disease. It's a lifestyle disorder. So it's a component. Type 2 diabetes is a component of metabolic syndrome. What is metabolic syndrome? Metabolic syndrome there should be at least 3 out of 5. Okay, 3 or more out of 5. Which are the 5? Either the person should have central obesity, or the person should have low HDL, or the person should have high triglycerides, high triacylglycerols, or the person should have high blood pressures, or the person should have impaired glucose tolerance or beyond. That means frank diabetes or even just impaired glucose tolerance. So out of these 5, any 3 should be there for the person to be deemed to have metabolic syndrome. And central to all of these is this. The central obesity that kicks off everything in metabolic syndrome. Okay, so in metabolic syndrome, central obesity means what? It's the visceral fat, visceral obesity. So the fat around the visceral organs. Visceral organs are not supposed to have a lot of this fat. It's not natural. We're not supposed to have fat around our visceral organs. Instead, we are supposed to have subcutaneous fat. So subcutaneous fat is what we need for um, times of stress, and in times of, let's say, when there's scarcity of calories, scarcity of food, maybe in winters when we need to generate heat, that time we need fat. Okay, or in periods of starvation when we don't get food, that time the subcutaneous fat is supposed to supply. So this subcutaneous fat is quite obedient. It will not disobey insulin. So subcutaneous fat is going to respond to insulin every time. So as long as insulin is there, insulin is the boss. Insulin is an anabolic hormone or a catabolic hormone. Insulin is a anabolic hormone or a catabolic hormone. So as long as insulin is there, it will not want the fat to be broken down. Insulin wants to build things. Insulin wants to push everything from the blood into uh, into uh, that means it wants to convert glucose into proteins. It wants to convert glucose into fat. It wants the glucose to be utilized by cells, basically. Okay, so that is why subcutaneous fat will not break down, lipolysis will not happen as long as insulin is present. That is in subcutaneous. But visceral fat, it doesn't, it's a rebellion. It's a rebel. Visceral fat is a rebel. It doesn't listen to insulin. Even if the insulin is present, in fact, even higher amount of insulin is also there, it will not listen. It will keep breaking down. So lipolysis occurs in patients with visceral fat because of insulin resistance. That is called insulin resistance. It's the property of visceral fat. It can't help it. That's how it is. It doesn't listen to insulin. So visceral fat, when it exceeds normal quantities, then it will keep breaking down, keep getting lipolyzed. So when there is lipolysis, it will release triglycerides and triglyceride levels will go up. So you will come across this very frequently. Like I said, in general health checkups, patients or relatives or neighbors will come and show you their report showing that the triglyceride levels have gone up. Why has it gone up? It's because they are having central obesity, visceral obesity. It is not listening to insulin. It is breaking down and producing a lot of triglycerides. Okay. Yeah. So as the triglyceride levels increase, there is an enzyme called cholesterol ester transfer protein. Cholesterol ester transfer protein will transfer cholesterol on from HDL towards the triglyceride levels. So HDL will keep reducing. Anytime you see high triglycerides, automatically you will see low HDL. Okay, so you shouldn't be surprised that when triglycerides are high, HDL will be low. But both are components of metabolic syndrome. Insulin resistance. So when there is insulin resistance, there will be, obviously there will be impaired glucose tolerance. Glucose levels will be high. Glucose not entering from blood into the cells. Glucose will remain high in the blood. And on top of that, this lipolysis, when it's liberating triglycerides, it is going to promote glycogenolysis, and there's going to be high blood glucose levels. Okay, so high blood glucose levels would be expected in any patient with insulin resistance. On top of that, it will also lead to increased blood pressures. Normally, what happens? Insulin will lead to fluid retention. Fluid retention with vasodilatation. Vasodilatation. So it has contrasting effects on blood pressure. Insulin, by itself, insulin will lead to fluid retention, but it will also lead to vasodilatation. So fluid retention should have caused increased BP, but because it has vasodilatory effects, it will not produce high blood pressures, insulin. But when there's insulin resistance, the resistance is more to the vasodilatory action. So they will end up invariably having high blood pressures. They'll have fluid retention and elevation in blood pressures because vasodilatation property of insulin is lost. There is resistance to that. So because of insulin resistance, there's vasoconstriction and there is fluid retention. Both these will push the blood pressures up. So that is yet another component of metabolic syndrome. But everything is kicked off by this visceral fat or central obesity. How do you define central obesity? In South Asians. In South Asians, central obesity is defined as the waist circumference in men exceeding 90 centimeters and in women exceeding 80 centimeters. So this is South Asians. Okay, there are different cutoffs for different races, but for South Asians, that means us Indians, it's 90 for men and 80 for women. That is the waist circumference. If one's waist, okay, how do you define waist? Waist is the midpoint between the subcostal margin, and the iliac crest. Okay, iliac crest laterally. Okay, laterally, if you can picturize laterally, this iliac crest is here at the bottom, and the subcostal margin, these are the ribs. The subcostal margin is here. This gap, okay, midpoint of this gap, midpoint of the gap between the subcostal margin and the superior most aspect of the iliac crest. This the midpoint between these two. Around this, you should measure the circumference. This will give you the waist circumference. So this waist circumference, if it exceeds 19 men, 18 women of South Asian race, then it is indicative that they have central obesity or visceral adiposity. Visceral adipose. Adipose is very notorious. Adipose, I told you lipolysis keeps happening. So adipose will keep liberating free fatty acids. I'm sorry, free fatty acids, which will then end up contributing to glycerol or triglycerides. But it will also lead to adipokine generations. So there are certain cytokines which are released from visceral fat, which are known as adipokines. Okay, they're cytokines which come from adipose tissue. That's why they're called adipokines. So chiefly resistin is one bad adipokine. There are some good adipokine. There are some good adipokines, but their concentration comes down in central obesity. These are adiponectin, and leptin also. So the levels of these come down. That's not good because it actually promotes insulin sensitivity. Adiponectin is good. If the insulin sensitivity has to increase, adiponectin does that. But if its levels come down, then the insulin resistance will increase. And resistin level, as the name itself suggests, that will increase insulin resistance. So adipose tissue will also incite a lot of inflammation. Both free fatty acids also incite inflammation. Adipokines also incite inflammation. So that is why obesity in general, it is an inflammatory state, pro-inflammatory state. Part of that inflammation will also lead to damage in diabetes, that is insulin resistance. Okay, so insulin resistance is the central, along with central obesity, is what is central to the pathogenesis of metabolic syndrome. And component of metabolic syndrome is impaired glucose tolerance or diabetes mellitus. Okay, pre-diabetes and frank diabetes, diabetes mellitus. So this is type 2 diabetes mellitus. So please remember, lifestyle disorder, calorie balance. If you can't use your calories, then the body will turn it into all this. It will not listen to insulin. Visceral fat will not listen. It will keep breaking down, generating free fatty acids. And that will lead to all these manifestations. Okay, that is type 2 diabetes. Sometimes we get something in between. It's called type 1.5 diabetes. That means it'll be a young person who will have maybe not very young. So beyond the age of 35, let's say, beyond the age of 35 years, if they end up developing insulin dependent diabetes, okay, maybe I should not use that term. They do require insulin for treatment. Insulin for treatment. So diabetes mellitus, insulin for treatment, and they have positive autoantibodies, which means for positive GAD65, positive ICA 512, positive zinc transporter 8. So they are positive for autoantibodies, require insulin for treatment, diagnosed with diabetes mellitus, but their age is 35 years and above. I'll tell you practically, what happens in these patients. They're also called as latent adult onset, latent autoimmune diabetes in adults. Okay, latent autoimmune diabetes in adults. That's why it's called LADA, the other name for type 1.5 diabetes, latent autoimmune diabetes in adults. So when do you suspect this? When practically, when you're trying to treat type 1 diabetes, it is not, I don't even attempt. I myself, I don't attempt treating type 1 diabetes. It is very, very challenging. For a person with type 1 diabetes, the insulin requirement fluctuates wildly, and so does their blood glucose level. So treating a patient with basal bolus insulin, if you have heard of this term, basal bolus regimen. So there you give a basal insulin plus you give a basal insulin plus you give bolus insulin. So we try to mimic the natural insulin release pattern. So natural insulin, how is it released? There is always a fasting amount of insulin. And each time that you have a meal, every time you have a meal, there's going to be a rise in blood glucose and the insulin will match that rise. Okay, so this is what you try and mimic. You give an insulin that is acting basally along with prandial insulin. That means each meal should be covered with additional insulin yeah, doses or insulin injections. Okay, so this is the basal bolus regime, which is ideal, which is similar to what happens physiologically. Physiologically, insulin release inside the body is also like that. There's a basal, and each time the person has food, there is an increase. There's a surge in insulin release. That also happens in phases, phase 1, phase 2. That is all physiology. But trying to treat patients of type 1 diabetes like this is the ideal way. It is so difficult because their requirement fluctuates. That's how it is. Any patient who doesn't have insulin in the body, to try and recreate the natural pattern of insulin is very, very difficult. So that is why now, luckily, we have insulin pumps. So subcutaneous insulin pumps are there. So, and these will titrate the insulin dose. It's going in continuously. Insulin infusions are going in subcutaneously continuously. So that will, luckily, it will match it will be proportionate to the sugar levels. So this is a much easier, much better option for type 1 diabetes, because trying to titrate their insulin doses is very, very difficult otherwise. So in a person who is above 35 years, if you're trying to treat with oral antidiabetics and they're not responding, then you start insulin and their sugars are fluctuating. Fluctuating means what? Suddenly, at one moment, the sugar will be more than 500. I'm sorry, more than 500. And then you try and titrate their insulin. By evening time, they'll go into hypoglycemia. So this kind of pattern, when you get like wildly fluctuating sugar levels, such high and then such low blood glucose levels, that means the person is having insulin deficiency. This is an indirect marker of, I'm telling you a practical point, that's all. Indirect marker of the person not having adequate insulin levels in the body. So this we generally see in type 1 diabetes, this kind of fluctuation. If you start seeing this kind of a diabetic pattern in an older individual, 40-year-old, 45-year-old, you're seeing this kind of a wildly fluctuating pattern of insulin requirement, you start thinking that the person has LADA. Okay, that is when you start suspecting that the patient has LADA. Then you send autoantibodies. You will get them positive. So there is a small percent of patients with type 1 diabetes who will present late. That is what is called as latent autoimmune diabetes in adults. Okay. So this is 1.5. So though the person is older, they are developing type 1 diabetes. There is another, what do you say? There is a diagonally opposite entity or a corollary, if you would like that word. Counterpart. That's the word I was looking for. There's another counterpart, and that is known as ketosis prone diabetes. Ketosis prone diabetes will be a person who has all the diabetes. So all the features of insulin resistance, obese person. Okay. I told you insulin is an anabolic hormone. So a person is insulin deficient means they'll be thin. Insulin, that's why weight loss is one of the features of diabetes mellitus, because insulin deficiency, the person can lose weight. So, but if the person is insulin resistance, they generally be obese. They have central obesity. So if a person who is obese, having central obesity, and ends up presenting in diabetic ketoacidosis. So remember, one of the differences between type 1 diabetes and type 2 diabetes is DKA is usually a feature of type 1 diabetes at presentation. DKA at presentation is type 1 diabetes. DKA in advanced stage can occur in type 2 diabetes also. Please remember, it's not that the DKA does not occur in type 2 diabetes, but it occurs in advanced stages. In advanced stages, the type 2 diabetic patient can also develop DKA. Okay, but if the person with insulin resistance features has a presentation, at presentation they have diabetic ketoacidosis, it's called KPD, ketosis prone diabetes. Okay, this is also a part of type 1.5. So when you thought that the person has type 2 diabetes phenotype, they'll present with DKA. And then you think that, oh, this person has presented with DKA, they must have type 1 diabetes. I need to treat them with insulin. So you start them on insulin. You'll test their autoantibody profile, it will come negative. So no antibodies. And gradually over the next few months to years, they end up their insulin requirements come down. So you can then maintain them only on oral antidiabetics. So oral antidiabetics and no insulin over years or maybe few months. Okay, over time, that means years, their insulin requirement starts to come down. This is another entity. You can just remember the name, ketosis prone diabetes. Likewise, LADA. Okay. So actually speaking, what's happening in type 2 diabetes is in type 2 diabetes, maybe I should not, hold on. In type 2 diabetes, what's happening is initially there is central obesity. And in order to try and overcome, there's going to be insulin resistance. To try and overcome the insulin resistance, there's going to be increased insulin synthesis from the beta cells. Okay, from beta cells of pancreas, islets of Langerhans. But what will this do? This will try and maintain blood glucose levels, normal blood glucose levels. So well before the diabetes or before pre-diabetes sets in also, the insulin levels will be elevated in patients with central obesity. So normal blood glucose is maintained. But eventually, they will start going into the phase of pre-diabetes or impaired glucose tolerance. And finally, they'll land up with type 2 diabetes mellitus. All this while, the pancreas are trying to produce more amount of insulin than normal, just to keep the sugar in check. Eventually, what will happen? The beta cells will start getting exhausted. Beta cell burnout. Okay. Beta cell apoptosis. Beta cell gets burnt out. Imagine if you guys study 16 hours a day. So how long can you keep studying like this? You will get exhausted. So the same thing happens with beta cells. They keep producing insulin. The demand is so much. Keep producing, not happening, not getting under control. So for some years, they'll be able to do it. But after that, they will end up having apoptosis. And this is also partly as a result of high glucose also. Okay, so high glucose itself can lead to beta cell apoptosis. That's called glucotoxicity. Glucotoxicity. High glucose causing beta cell death, beta cell apoptosis is called as glucotoxicity. So you have to prevent this. That is the reason for aggressive blood glucose control. At this stage, secondary prevention, aggressive blood glucose control, you can at least conserve the remaining beta cells for future. And of course, avoid complications. So once beta cell apoptosis happens, the person will land up with low insulin. So insulin levels start coming down. And this will only worsen. It's a vicious cycle. This will worsen the blood glucose. So eventually, advanced stages of type 2 diabetes also, they'll have low insulin level. So this is when the person starts becoming thin. So type 2 diabetes, many years after being diagnosed with diabetes, 10 years, 15 years, 20 years later, they start losing weight. They were hefty to begin with. But now, after 15, 20 years of having lived with diabetes, they start losing weight. That is because the beta cells have got burnt out. They've gotten apoptosed because of combined hyper secretion of insulin and glucotoxicity. That is why now their insulin levels are coming down, and that is why they are losing weight. Insulin is an anabolic hormone. No insulin, everything will start breaking down. Proteins will start breaking down. Lipolysis will start happening. So person will start losing weight. So that is one more manifestation of diabetes. Okay. Yeah. So this is about type 2 diabetes. The fact that they end up having initial insulin resistance leading to hyperinsulinemia. and all the hyperinsulinemia features will develop. Okay, what are the hyperinsulinemia features? Acanthosis nigricans. Okay, the dark patches, dark hyperkeratotic patches that you see on the, especially on the nape of the neck. You can see those dark patches on the face also. Okay, very common. If you see dark patches over the face, no, one of the differentials is facial acanthosis. Facial acanthosis is very strongly linked to coronary artery disease. So if you see patients with facial acanthosis, small patches will be there, usually here, forehead or on the sides. So if a person has facial acanthosis, so very strong, there's a strong association of facial acanthosis with the presence of a coronary artery disease. Okay, that's the level of insulin resistance that they have. Okay, so acanthosis nigricans is because of insulin. Insulin is an anabolic hormone. So the more the amount of insulin, the skin also becomes hyperkeratotic. Skin develops acrocordons. Acrocordons is the medical term for skin tags. You'll see skin tags, multiple skin tags. Okay, multiple skin tags, acanthosis nigricans. These are skin manifestations of hyperinsulinemia. Why is the insulin level high? To try and counter the insulin resistance. Okay, as a result of beta cell hypersecretion, too much of activity in the beta cells, eventually they'll get burnt out. So the person will land up with insulin deficiency. Then they can land with DKA, diabetic ketoacidosis. Okay. So initial stages, the insulin type 2 diabetes mellitus patient is obese. Later on, they develop, they become thin. Okay, type 1, type 2, type 1.5. What are the other types of diabetes mellitus? There's monogenic diabetes, that is MODI. MODI stands for, anybody? What does MODI stand for? MODY? So what we talked about type 1 diabetes and type 2 diabetes, these are polygenic. Type 1, type 2, they require uh, a predisposing factor, predisposition, plus environmental, very good drishti, maturity onset diabetes of young people diabetes, excellent Kirti. So they require predisposition plus environmental factors. That means it's an interplay between both the person's individual constitutional characteristics as well as environmental exposures. Only then they develop either type 1 or type 2 diabetes mellitus. So type 1 diabetes, there are certain HLA associations, okay? Certain HLA associations of type 1 diabetes. Like for example, HLA DQA1, there is B1. In that also, there is 0301 DQA1. So HLA DQA1 0301, DQB1 0302, and 0201. These are strongly linked. These HLAs are strongly linked to type 1 diabetes. So this kind of a predisposition, HLA association, along with that, some environmental triggers. It could be as innocuous as a viral infection. Some viral infection may trigger it. The autoimmune, something that triggers off the autoimmune process in a predisposed individual, already predisposed individual. Okay, likewise, type 2 diabetes mellitus, South Asians. So we are always going to be at risk for diabetes mellitus. Traditionally, historically, we were mainly an agrarian economy. We had agriculture that most of us or most of our ancestors would get involved in, and we didn't have lots of food, right? So it was never a case of us having a lot of food available. The availability of food was limited, and work was much more intense. That is why our race were never used to such high calories. So as South Asians, we'll always have this predisposition. And now the environment is right. Environment is perfect for rampant diabetes, and that's why it's happening. So these are all polygenic diabetes. Monogenic diabetes is there is a single gene disorder, gene mutation or a gene change, genetic change, which results in diabetes mellitus. So that these are known as maturity onset diabetes in young. So these are autosomal dominant disorders. So consider this in individuals who get diagnosed with diabetes at a young age, but they're not requiring insulin, not necessarily requiring insulin. For example, there are different types of diabetes, different types of MODIs. Okay. Among them, MODI 3 is the most common. MODI 3 is the most common. So it will be a young person, maybe a 25-year-old person or somewhere around that age. So most common type of MODI is MODI 3. And such an individual, all they require is some sulfonylurea. Okay, with the sulfonylurea, they are well controlled, well controlled. So that makes you think, such a young individual having well-controlled diabetes requiring only oral anti-diabetic agents. First of all, if it's an insulin, if it's a type 1 diabetes, sulfonylurea is of no use, no role. You cannot, because already the pancreas beta cells are not there. You can't expect whatever is remaining to be triggered, be stimulated by sulfonylureas. That's how they work. No, they stimulate beta cells for insulin production. You can't use that in type 1. Yet, if this young individual is getting controlled with just the sulfonylurea, and you check their family history, so the father has it, the grandfather has it. So there is a family history of well-controlled diabetes, not much complications. There's no history of retinopathy, nephropathy, nothing. Then in that case, you suspect MODI. Okay, maturity onset diabetes of the young. It's MODI 3 is the most common one. What is the gene affecting? It's affecting something called as hepatic nuclear factor 1 alpha. MODI 3 affects hepatic nuclear factor 1 alpha. There are different MODIs, okay, from 1 to at least 6 are there. Okay, so different MODIs are there. In fact, there's more than there's close to 20, I think, 20 MODIs, but we don't need to know all of them. They're rare. They're rare. They get masked. Okay, a MODI patient may end up developing type 2 diabetes with the kind of lifestyle we have. So we end up considering that patient to have type 2 diabetes only, not MODI. But keep in mind, MODI is one subtype of diabetes mellitus purely because of one gene mutation that usually result in insulin release problems. So that one mutation will cause the diabetes to get manifest. Endocrine manifestations. Okay. Blood glucose. You guys tell me this. Which hormones reduce blood glucose? And which hormones raise blood glucose? Which means these are counter insulin hormones. They're called counter regulatory hormones. Counter insulin hormones. Which is the chief counter regulatory hormone? That means when there is hypoglycemia, which hormone will react the fastest to try and raise the blood glucose levels? Glucagon. Excellent, Dhruvi. So glucagon is the chief counter regulatory hormone. Excellent, Samay. So glucagon is something that will push the sugar up. What about the others? Which are the other counter regulatory hormones? Anytime the sugars go too low, hypoglycemia, which hormones will try and bring the sugar level up? 4 you have to remember. Cortisol. Excellent, Dhruvi. Cortisol will come slightly later. So when you diagnose, how do you diagnose growth hormone? Samay, excellent. That's also last. How do you diagnose? What symptoms will a patient with hypoglycemia experience? What will they feel when their sugar levels are very low? What symptoms will it produce? Dizziness. Excellent, Kirti. Giddiness. Samay. Sweating. Dhruvi. Correct. Sweating. Palpitations. Tremors. Okay. All these are features of increased sympathetic activity. So which means catecholamines. All the catecholamines are counter insulin hormones. So you are thankful to these because they will produce some manifestations indicating that the person has hypoglycemia. So you need them. Correct. So these are the counter insulin hormones. Anytime their concentration is high, for example, a glucagonoma, for example, a pheochromocytoma, for example, Cushing's syndrome, for example, acromegaly. Anytime that their concentration is high, the chance of them having diabetes increases. Okay. Many other hormones don't like insulin. Like, for example, estrogen, progesterone, both don't like. So that is why you get GDM, gestational diabetes mellitus. Gestational diabetes mellitus, I didn't describe that as a subtype of diabetes. It's close to type 2 diabetes. Insulin resistance is at the heart of gestational diabetes mellitus. So it tends to occur in the rather in the second trimester. Beyond 24 weeks is when you get gestational diabetes. That is because of the rising hormone levels or the prolonged rise in these hormone levels, which have anti-insulin activity. So that is why you can develop gestational diabetes mellitus. So all these are examples of hormones which, if they are in excess, they can produce diabetes. They can contribute to diabetes. Which are the good hormones for blood glucose? Which will lower the blood glucose? Obviously, we know insulin does it. Anything else? Which other hormones are good? I mean, which hormones will try and bring down the glucose level, blood glucose level? Apart from insulin. Anybody? Other hormones which try and bring down the blood glucose apart from insulin. So there's one which pretends that it likes glucagon. One hormone that pretends to like glucagon. That's why it's been named like that. That it likes glucagon. But actually it doesn't like glucagon. It dislikes it. It suppresses glucagon release. It actually increases release of insulin. That is why it is known as glucagon-like peptide. Very good, Samay. So glucagon-like peptide 1, GLP-1. There's GLP-1, there's GLP-2 also. But GLP-1 is what is responsible for actually increasing insulin release and suppressing glucagon release. So that is one hormone that is trying to bring down the level of blood glucose level. I mean, blood glucose. Which else? Which others? There's one more peptide, no? So you can use this for treatment. You know that GLP-1 is helpful in reducing somatostatin. Somatostatin is very complicated, Sushmita. Good answer. Somatostatin, unfortunately, it's a little unpredictable with regards to blood glucose control. So somatostatins, good answer. It can sometimes excellent. That is the answer. Amylin, Sushmita, excellent. Amylin. Amylin is co-secreted with insulin. It is also secreted together with insulin. It's proportionate to how much insulin is being secreted. So that is why you can use this also as treatment. You can give amylin agonist. You can give amylin agonists for treatment. So I was talking about type 1 diabetes, drugs which can be used. So teplizumab to prevent stage 2 to stage 3 progression. Insulin, of course, has to be used in any type 1 diabetes. Along with these, amylin agonists like pramlintide can also be given. Pramlintide. In type 1 diabetes, pramlintide. Okay, the advantage of pramlintide over insulin is it actually reduces weight. That's what amylin does. Amylin reduces blood glucose by reducing appetite and delaying gastric emptying. GLP-1 promotes insulin secretion, reduces glucagon release, and delays gastric emptying. Glucose dependent insulinotropic peptide, GIP, also has a glucose lowering effect. So you can use these for treatment of diabetes mellitus. And you can expect that these hormones, when they're in excess, can produce diabetes mellitus. So there are some endocrine causes for diabetes. Then there are genetic causes. Several genetic syndromes are associated with diabetes. So Downs, Klinefelters, Turners, then all these trinucleotide repeat. Any examples of diseases which occur due to trinucleotide repeats? I'll give you the trinucleotide repeats. You can tell me. GA trinucleotide repeat leads to many of these trinucleotide repeat disorders. GA is for Friedreich's ataxia, frataxin gene. CTG, that is for myotonic dystrophy. So it's also called as dystrophica myotonia. Myotonic dystrophy, dystrophica myotonia. So diabetes mellitus and dystrophica myotonia. You can remember like that, DM and DM. Okay, CGG is Fragile X syndrome. These are all tandem nucleotide repeats. Okay, trinucleotide repeats. Fragile X syndrome. These are all associated with diabetes mellitus. Okay. Then there are insulin resistance syndromes. There are several syndromes. Okay. But you may not know all of them at this point for university exam purpose. But just remember that there are certain genetic syndromes which are associated with diabetes mellitus occurrence. Okay, Wolfram syndrome and all. There are several syndromes which have diabetes as a component. Okay, monogenic diabetes is the only problem. These genetic syndromes, diabetes is part of overall syndrome. There are other components also. Okay, that's about the types of diabetes, including GDM. Okay, GDM I'm not gone into, but it is basically because of counter-regulatory hormone excess in the form of the gonadal. That means the estrogen and progesterone. Okay, so pathophysiology, I guess we have covered it. Type 1 is mainly autoimmune, and it will pass through an initial stage of only autoantibodies positive, sufficient beta cell reserve. That is stage 1. Then the beta cell reserve starts coming down, the glucose starts going up, but not yet crossing into diabetes. That is stage 2. And stage 3 is finally very few beta cells present. Then they'll have frank hyperglycemia and symptoms. So remember, one of the differences between type 1 and type 2, diabetes mellitus. So what are the other differences? Let's start discussing. Type 1 age will be younger, whereas it will be older in type 2. Okay, this I'm talking about maybe till people who are born in their 60s, 70s, 80s. Okay, maybe 90s. 90s also difficult. Till 70s and 80s. Now, after 90s, whoever is born, they are getting diagnosed younger and younger. So this is not a very strong point. Keep in mind, you can get type 2 diabetes at a young age because of the kind of lifestyle exposed. Right. What are the other differences? This is autoimmune, whereas a lot of autoimmune, that means there's a lot of constitutional predisposition, whereas this is more of a non-communicable disease. This is a lifestyle disorder. Okay. And in terms of symptoms, they will have prominent osmotic symptoms. Osmotic symptoms are high. They may remain asymptomatic. Type 2 may remain asymptomatic for a very, very long time. Need not have any symptoms. Okay, they may have signs. You may notice it on examination. They may have acanthosis. They may have skin tags. There'll obviously be obese, central obesity. All that will be there. Signs will be there, but not too many symptoms till the end, unfortunately. What happens to insulin? Low insulin. This is initially insulin resistant, then progresses into deficiency. Okay. Treatment wise, so autoimmune, so diagnosis requires autoantibodies. This one requires mainly blood glucose levels itself. If you want, you can do something called HOMA-IR. So homeostasis, HOMA-IR it's called. Homeostasis and insulin resistance. So, but you need not. Most often when we diagnose type 2 diabetes, we don't really look for all this HOMA-IR. For HOMA-IR, you need to do a fasting level of blood glucose, fasting level of insulin, and then check their ratio. So all that we generally don't do. Okay, we can just remember that term, HOMA-IR. That is the homeostasis for insulin resistance. testing for type 2 diabetes. Okay, treatment is mainly insulin, but some other drugs. But you can use OAD plus or minus insulin for, and you can use surgery also. Plus lifestyle, of course. Lifestyle measures, top for type 2 diabetes. That has to be one of the top priorities for type 2 diabetes. Okay. Right. But together what will they do? Together they will cause high blood glucose. So why is high blood glucose bad? So what if blood glucose is high? What harm is it going to do? High blood glucose. So remember, there are some direct effects. Direct effects include osmotic effects. Okay, not so bad. So if he's too thirsty, he'll just drink lot more water. So if he's passing a lot of urine, he'll just drink more water and can try and balance it out. So direct effects, one is osmotic. Otherwise, it can lead to increased infections, especially urine. Right? So high urine glucose can predispose to infections. It can also impair wound healing. And finally, acute complications. Because of high blood glucose, acute complications like DKA and HHS. These are the acute complications as a result directly because of high blood glucose levels. What about indirect effects? Indirectly, so what if the blood glucose levels are high? Basically, high blood glucose is an enemy of blood vessels. So diabetes mellitus is basically a blood vessel disorder. It's an angiopathy. If it affects small vessels, then it is a microangiopathy. If it affects large vessels, then it is a macroangiopathy. So how is it going to trouble blood vessels? Small blood vessels, it will lead to basement membrane thickening. Already they're very small. If you end up causing thickening of their basement membrane, small vessels, in that you start thickening their basement membrane means their lumen will start getting occluded. So microangiopathies are basically luminal occlusion due to basement membrane thickening. What about large vessels? Problem is more complex actually. Large vessel, but in one word, if you had to summarize, it is atherosclerosis. It is an atherosclerotic condition, diabetes mellitus. Large vessels, it will produce atherosclerosis. Small vessels, they're too small to produce atherosclerosis. So they just increase the basement membrane thickening. They increase the extracellular matrix. Because extracellular matrix is increased, the lumen by itself gets occluded. But here, in larger vessels, it's going to cause atherosclerosis. So it's going to increase smooth muscle proliferation, everything that is detrimental for the large blood vessels, and enhances their risk for atherosclerosis. So increased smooth muscle proliferation, increased extracellular matrix, endothelial dysfunction. All these will happen. Endothelial dysfunction, procoagulant state. It will lead to a procoagulant state. So there'll be a lot of thrombosis. So that is why, any patient you come across with diabetes mellitus, it's you have to presume that already they have some form of coronary artery disease. So very often what we do is we start them on primary prevention with antiplatelets and we start them on aspirin and atorvastatin for primary prevention. Okay, so patients of diabetes mellitus, whoever is diagnosed with diabetes mellitus, most often they'll have a coronary artery disease. It's almost equivalent. They're called coronary artery disease equivalent. Type 2 diabetes is a coronary artery equivalent. So that's why we start them on antiplatelet and atorvastatin as primary prevention. Okay, so this is the other aspect of pathogenesis. So it's going to cause trouble to the blood vessels, either micro or macro angiopathy, thereby leading to their complications. Okay, this is in simplest terms what diabetes will do. Okay, right. Clinical features, I told you. Osmotic symptoms, much more common in type 1, rare in type 2. If type 2 diabetes patients have developed osmotic symptoms, they're probably very advanced type 2 diabetes mellitus. Beta cells have gotten burnt out. Glucotoxicity has destroyed all the beta cells. Now their insulin level is coming down. They're behaving like type 1 diabetes. They will require insulin treatment. They have lost weight. They used to be insulin resistant. They used to have a lot of visceral fat. Now they're losing weight. They become thin. So they will require insulin treatment. Osmotic symptoms, more common, much more common in type 1 than type 2. Okay. Weight loss despite good appetite. This is a differential diagnosis for hyperthyroidism. So in thyroid hormone excess also, similar symptoms happen. No? When the person is eating, he's having polyphagia but losing weight. This can happen. Significant weight loss they'll have. Type 2 diabetes. Okay, I'm talking about type 2. Type 1, anyway, it'll be at a younger age. So generally, they wouldn't have put on so much weight. But type 2, definitely, they would be insulin resistant for so long. Hyperinsulinemia takes a toll. Then the weight starts coming down. So that is weight loss despite good appetite. Then you have to remember acanthosis nigricans and skin tags. Acanthosis nigricans and skin tags. That is acrocordons. Acrocordons. Maybe you can remember this term. It's called diabetic dermopathy. Diabetic dermopathy. So a lot of times these help to make a diagnosis of, dermopathy. They help to make a diagnosis of long-standing diabetes. So these are just macules, hyperpigmented macules over trauma points. That means shins. So when you notice the shins of a patient with long-standing diabetes, you'll notice hyperpigmented macules, pigmented macules over the shins. These are known as diabetic dermopathy. It's an indicator of long-standing diabetes. So such an individual will probably be thin because long-standing insulin resistance has now led to beta cell burnout and insulin deficiency. So if you see a thin individual with type 2 diabetes, most likely it's a long-standing diabetic. If you see diabetic dermopathy on their shins, it's probably a long-standing diabetic. If you see type 2 diabetes patient with diabetic ketoacidosis, it must be a long-standing diabetes. They develop diabetic ketoacidosis because they don't have insulin anymore. Okay. Then there are certain complications which don't come under micro or macrovascular complications. So, like for example, cataract, eye complications. So, cataract is much more common in type 2 diabetes mellitus or in diabetes mellitus in general. So, cataract is said to occur because of sorbitol excess. So, because of increased sorbitol. Likewise, glaucoma. Glaucoma is also more common in diabetes mellitus. Yeah. Okay. Why the angiopathies occur is because of AGE, advanced glycosylated end products, or advanced glycated end products. I'm sorry, advanced glycated end products. Okay. Otherwise, actually, most patients will be asymptomatic. Most type 2 diabetes patients will be asymptomatic. Type 1 will develop symptoms because of insulin deficiency. Type 2 diabetes, for years together, they'll be asymptomatic. That's why you need to screen the general population as a whole. Okay. That is clinical features. Now, what about complications? This is where they present to us. A lot of times, especially in India, they'll present to us with complications. They won't present to us for routine screening. They won't present to us with mild symptoms, osmotic symptoms. They'll present with complication. So what are the complications? So there is acute and there's chronic. And in acute, we have most prominent diabetic ketoacidosis. So simply put, Diabetic ketoacidosis is a state of very high counter regulatory hormones in the setting of very low insulin. Patient has absolute insulin deficiency and very high counter regulatory hormone levels. Why the counter regulatory hormones are high? Because the person is in stress. Which is the stress hormone? Which hormone do we need when we are in stress? So we need two major stress hormones. One is the fight, flight, fright hormone, and the other one is the cortisol. Okay, very good name, cortisol. So cortisol, why is it a stress hormone? Because cortisol has a permissive action for catecholamines, just like thyroid hormones have a permissive action for catecholamines. Like that only, cortisol also has a permissive action for catecholamines. Also, cortisol will lead to increased neutrophils, demargination of neutrophils. So it will suppress eosinophils, everything that is associated with the stress response. Cortisol. Okay, it will increase glucose levels. Glucose is increased, so the inflammatory cells can try and take up that glucose and fight whatever the inflammation is. So basically, cortisol is also a stress hormone. So when these levels are high, so that means a type 1 diabetic patient who is suddenly under stress. What kind of stress? It could be an infection. It could be, most often it's an infection. Or it could be a surgery. Okay, burns, something, some sort of intense stress, very major trauma, burns. Okay, myocardial infarction, not so common in type 1, but type 2 diabetes, advanced type 2 diabetes patient who develops MI can develop diabetic ketoacidosis as a precipitating factor. So something which has caused stress and elevated stress hormone levels, but the person had no insulin in their body. That's why the person has gone into DKA, diabetic ketoacidosis. So what is this? When there is this lopsided ratio, no, of low insulin and high counter regulatory hormone, the glucose levels will be high. How high? Even 200 milligram per deciliter is enough. This is the latest. Earlier 250 was the cutoff. Now 200 milligrams is sufficient to consider a diagnosis of DKA. Along with that, of course, what's going to happen? Because blood glucose levels are up, counter regulatory hormone is up, insulin is not present, glucose levels are up. So they'll have all osmotic symptoms. Patients of DKA, they'll have osmotic diuresis, that means polyuria, polydipsia. So they are going to be in an osmotic state, hyperosmotic state. And as a result, now cells are hungry and they're not getting any glucose. Glucose is all in the blood and going in the urine, but not going inside the cells. So they need an energy source. What is that energy source? There's going to be lipolysis. No insulin, subcutaneous fat will start breaking down. Lipolysis. Lipolysis will also end up promoting ketogenesis or ketone synthesis, ketone body synthesis, especially for the brain. Okay, ketone bodies, they are a good source of energy for the brain. Brain is not getting glucose. Glucose is essential for brain, but it's not getting glucose. At least, okay, lipolysis is releasing free fatty acids. Can the brain utilize free fatty acids? No, because it doesn't cross the blood-brain barrier. Free fatty acids don't cross the blood-brain barrier. Glucose crosses, but there's no insulin to push the glucose into the brain neurons. So finally, it is left for the brain to use ketone bodies. Ketone body synthesis happens, which can happen only during insulin deficient states. Even a little bit of insulin is enough to prevent ketone body synthesis. So if you see a patient with who has very high blood glucose levels, but is receiving insulin, don't worry, they cannot go into DKA because any amount of insulin will prevent ketogenesis. Okay, so that's the problem now. When the ketone bodies, these are acidic. So these are keto acids and they will lead to a reduction in pH. And that is what is the problem. With the reduction in pH, there's going to be cardiac function that is suppressed. cardiac function is suppressed. They land into hypotension. They land into Kussmaul's breathing. Okay, so basically they've lost a lot of fluid because of osmotic symptoms and high glucose levels. Plus they're developing acidosis and compensatory respiratory alkalosis, which is Kussmaul's breathing. And they're developing hypotension, cardiac function being suppressed. So this is what is at the heart of diabetic ketoacidosis, a state of high counter-regulatory hormone levels and low insulin levels, usually precipitated by something. It could be as trivial as missing their medication. So just missing their insulin level, their insulin dose in the setting of fever. So just a mild fever, but they missed their insulin. That can be enough to precipitate DKA if the ratio is in favor. Ratio of counter hormone to insulin. Okay, so I'll ask you one thing. Suppose you're in, this is the question that our endocrinologist used to ask us. If you are working in a PHC and you notice that a patient has been brought in, young person, 25-year-old, hyperventilating, Kussmaul's breathing, air hunger, Kussmaul's breathing, hyperventilating. You smell the breath, it is fruity odor, fruity breath. Fruity breath is because of acetone. Acetone is a ketone body. Which are the three ketone bodies? Acetone, acetoacetate, and beta hydroxybutyrate. The final compound that is formed is beta hydroxybutyrate. Okay. Ketone decay itself is a big topic actually. So what is a ketone body? This, when there's a C double bond O, that's a ketone body. So acetone, acetoacetate, and acetate and beta hydroxybutyrate. These are the three butyrate, sorry. These are the three ketone bodies, out of which acetone is volatile. It will just go out. If it's there in blood, next moment it will come out in the breath. So acetone contribution, and it's not acidic. So it's not going to contribute too much to the decay. Acetoacetate and beta hydroxybutyrate are acidic, but sorry. Sorry. Something happened. What happened? I got logged out of Zoom. I'll just log in. Okay. Yeah. So as I was saying, acetone is what imparts a fruity odor to the breath. Acetoacetate is acidic, but the end compound during ketone body synthesis, the last step is beta hydroxybutyrate. So more severe the ketoacidosis, the more beta hydroxybutyrate you expect. So that is what is usually measured. When you're diagnosing diabetic ketoacidosis, you measure the concentration of beta hydroxybutyrate. Earlier tests, classically what was taught was testing for, so how do you diagnose, okay, diabetic ketoacidosis? I'll mention here. So how do you diagnose DKA? Earlier traditional testing, look at the anion gap. If the anion gap is high, it's an indirect evidence that yes, person has high blood glucose with high anion gap. DKA is a possibility. Little more direct evidence, you go for Rothera's test. Rothera's reagent is nitroprusside. Nitroprusside will detect this. It will detect the C double bond O. Now, unfortunately, beta hydroxybutyrate is not a true ketone body. It does not contain this C double bond O, but it is the end product of ketone body synthesis. So the more severe the ketone bodies, or the more severe the DKA, the more ketone bodies that are synthesized, the more the proportion of beta hydroxybutyrate, lesser acetoacetate. Okay, the reverse is true when it is recovering. During recovery, all the beta hydroxybutyrate is getting converted into acetoacetate. So this concentration rises, this will be low. Whereas during DKA, all acetoacetate is getting converted into beta-hydroxybutyrate. That is why for diagnosis, when you use Rothera's agent, it will not detect beta-hydroxybutyrate. It will give a falsely low interpretation or impression of ketoacidosis. That's why we go first direct serum beta-hydroxybutyrate testing. So if this is more, if this is increased, the cutoff is 3. If it is more than 3 milligram per deciliter, it's considered as elevated beta-hydroxybutyrate levels in the serum. So these are the ways to make a diagnosis of diabetic ketoacidosis. This is with, I told you, blood glucose levels. This will confirm the ketoacidosis part. Then the blood glucose level should be at least 200 milligram per deciliter. Okay, and look at the pH. pH should be less than 7.3. Look at the bicarbonate level, serum bicarbonate level. Bicarbonate level. It should be less than 18 milliequivalent per liter. So this much is enough to make a diagnosis of diabetic ketoacidosis. Okay. So there's so much to discuss. Yeah. So what I was asking is, if a patient, you are in THC and the person is brought in with the fruity odor and acidotic breathing, you don't have insulin. Suppose you're in the PHC and by chance insulin is not there. Can you save this patient, DKA patient? DKA, before the invention of insulin, DKA was fatal. But still, when this patient is brought into your PHC where there's no insulin, you are the first responder. Can you still save this patient's life? What is the first? DKA is no doubt deadly, but what is the first cause for death in DKA? It is not the hyperglycemia. Hyperglycemia is not going to be fatal. Ketosis with acidosis is going to be fatal. Excellent, Dhruvi. Dehydration correction. So because of the high glucose, they have lost a lot of fluid, lots and lots of fluid. Okay. Unimaginable amount of urine output they would have produced. They would have lost at least 6 to 8 liters. So you need to correct that. That will save their life. Immediately they'll save, their life will be saved. Then the acidosis needs to be corrected. At least before you refer to the next center, you can at least start them on IV fluids, correct their intravascular collapse status, and then start referring them. They can start their journey to the next nearest higher center, and their insulin is available now. Of course, that scenario is very hypothetical. Everywhere insulin is available. But still, what you should focus on is don't focus on only insulin. Focus on the dehydration correction. Focus on intravascular volume restoration. So in treatment of DKA, when you're treating DKA, treatment of DKA, remember step 1 is IV saline. Okay. At least 3 liters in the first 1 hour. Because they would have lost a lot of fluid, intravascular volume collapse. If you don't do this, they may not live long enough for any other step. So step 1 is a priority, IV fluid. Next, check the serum potassium level. Is it normal? If it is normal, proceed to step. Okay, this should be step 2. Step 3. Step 3 is insulin. Insulin is what is the definitive treatment. If you want to stop the ketone body synthesis, you have to give insulin. Nothing else will stop it. So you have to give insulin. You need to give it at 0.1 unit per kg per hour infusion. Okay, what is your target when you're giving insulin in DKA? You try and reduce the glucose by, blood glucose by 50 to 75 milligram per deciliter per hour. So you need to monitor the blood glucose level every hour, and this should be your target. If your target is not getting achieved, you increase the insulin infusion dose. If you are overshooting, you reduce the insulin infusion dose. So if in case it's not normal, don't give insulin. Your first priority is correct. Sorry, if it is low, I meant if potassium level is low, don't give insulin. You need to correct it. Correct the hypokalemia. Okay. Because if the potassium is already low and you give insulin, it will further lower the potassium. That can be deadly. That can be fatal. So do no harm. Keep in mind, first thing, correct their intravascular volume status. Second, look for potassium. Potassium is fine. Then start insulin. Okay, this you can at least delay insulin by 1 hour. 1 hour, first 1 hour, just give fluids. Then start insulin, provided your potassium comes back normal. Potassium is low, you correct it. If it is normal, give insulin. Monitor blood glucose levels. Okay, and monitor beta hydroxybutyrate level. Your target here is not blood glucose normalization. It is beta hydroxybutyrate levels normalization. Okay, so till when do you continue insulin? Not till the blood glucose level is normalized. If the blood glucose level is normalized, but beta hydroxybutyrate level is still high, you need to continue insulin. In order to prevent hypoglycemia, you add insulin to dextrose. Because you're not giving insulin mainly to correct the blood glucose, you're mainly giving it to stop the ketone body synthesis. Is that clear? I hope that point is clear. You're going to give insulin even if the blood glucose level has normalized. I told you, even if you started with 200 milligram per deciliter, the person had 200 milligram per deciliter but had ketone body synthesis. So you have to give insulin because you want to stop the ketone body synthesis. But then if you give insulin with the sugars being 200 and you reduce it by 50 milligram per deciliter, it could soon go into hypoglycemia, very low. You can't risk that. So in such patients, you can give insulin mixed with dextrose. The dextrose to prevent hypoglycemia, but the insulin to reduce or stop the ketone body synthesis. So your target in DKA is to stop the ketone body synthesis. Normalization of beta hydroxybutyrate level is your target, not the blood glucose level normalization. Clear? Insulin here in DKA is not for high glucose. It's for stopping ketone body synthesis. Okay. This is briefly about DKA. More common in type 1 or advanced type 2. Okay, so what are the differences between HHS and DKA? Remember, diabetic ketoacidosis is truly acute complication, whereas HHS is subacute. HHS doesn't develop over minutes to hours to days. It takes weeks for HHS to develop. So I told you, myxedema coma is a disease of the neglected. Nobody's been looking after that person. That's why they've developed myxedema coma. HHS is also similar. If you come across patient with HHS, it means nobody has been looking after them, because you can't develop HHS in matter of hours to days. It takes weeks. So weeks of hyperglycemia will lead to HHS. So again, osmotic diuresis is the problem. And it is not few hours. So they'll have osmotic diuresis for so many days. They'll have very, very large amount of fluid deficit. So here also osmotic diuresis, but lesser fluid deficit. Comparatively less fluid deficit. Much more in HHS. Okay. Type 1 diabetes mellitus only. This HHS can occur in type 2. I'm sorry. HHS occurs only in type 2 diabetes mellitus. Type 1 or advanced type 2 also you can develop DKA. Advanced type 2 diabetes can develop DKA. Okay. Renal dysfunction is much more common in in HHS, because many weeks of osmotic diuresis would have led to acute kidney injury. So renal dysfunction is more common in HHS. What about treatment? Very good outcome. In fact, DKA mortality in this day and age should be you should not accept it. You should not have a person dying of DKA. In 2024, there should be no patient dying of DKA. So mortality should be 0, ideally. But okay, we'll keep it as less than 1%. But HHS, no, whatever you do, even after you give them fluid correction, you give them insulin, they don't have acidosis. Okay, so that is another difference, of course. pH will be low. pH in HHS may be low because of the renal injury. Otherwise, there's no ketones. So no ketones, no ketone bodies. But mortality is high. Even with at the most advanced center also, if they receive treatment with all textbook steps also, mortality is at least 15%. It's too late. The problem is the osmotic diuresis has led to neurological dysfunction. They'll both have neurological dysfunction. Okay, HHS, they'll be totally dehydrated, lots of fluid lost, more than 10 liters of body fluid lost, neurological dysfunction, renal dysfunction, irreversible. So 15% mortality in HHS, despite the best of treatment. DKA, practically speaking, I'll tell you, I've never seen a patient of DKA dying because now insulin is available everywhere. Fluids are available everywhere. So mortality in DKA this day and age should be unacceptable. You should not allow a patient of DKA to die. HHS, it's unfortunate. It's a disease of neglect. By the time the patient presents to us, they may well have crossed that point of no return. You try and correct their fluid deficit and insulin, still they may succumb. Okay, these are acute complications of diabetes mellitus. What about chronic complications? These in themselves are actually big chapters. Few points we'll discuss. Okay, microangiopathic. I told you basement membrane thickening, AG, advanced glycosylated end product deposition leads to basement membrane thickening. So what are the chief microangiopathic complications? It can lead to retinopathy. In that also we have non-proliferative diabetic retinopathy, proliferative diabetic retinopathy, and macular edema, cystoid macular edema, clinically significant macular edema. Okay. Then we have nephropathy and we have neuropathy. These are the chief microangiopathies. Okay. Retina annual fundus examination is necessary for all type 2 diabetic patients. All patients of type 2 diabetes should undergo annual retinal examination, fundus examination, dilated fundus. They should have had a dilated fundus examination. Okay. Nephropathy. Okay. So the lesions, non-proliferative diabetic retinopathy, there may be just a few cotton wool spots or retinal hemorrhages may be there, microaneurysms may be there. Okay. Whereas in proliferative, there is neovascularization. You see new vessels in the optic disc. So that's bad news. Because when the new vessels are formed, that new vessel is getting formed because of VEGF, vascular endothelial growth factor. So it's going to be leaky. It's going to lead to retinal hemorrhages, which when the retinal hemorrhages can lead to retinal detachments also. So permanent vision loss. So you can't afford for that to happen. So tight blood glucose control and annual fundus examination necessary for all patients of diabetes mellitus. Okay, macular edema can also occur and lead to vision loss. How do you prevent this or how do you treat this? You have to actually, there is a retinal ischemia, and that ischemia is causing increased VEGF, and that is causing neovascularization. So if you want to stop the neovascularization, you eliminate that ischemia and that need for new vessels. So you eliminate it by actually obliterating the retina with lasers. So it is counterintuitive. You wouldn't have thought of it like that, but that is the actual principle. You're obliterating the retina with laser therapy to try and stop that demand for new blood vessels. So pan-retinal photocoagulation is what is done for proliferative diabetic retinopathy. Otherwise, you can use VEGF, anti-VEGF agents like ranibizumab and bevacizumab. These you can use to try and oppose or negate the VEGF. Okay. This is about little bit about retinopathy. Nephropathy. Again, this is a very vast topic in itself. What you can know is it's the most common cause of CKD, chronic kidney disease. The most common cause is diabetic nephropathy. Look out for albuminuria. Actually, there are 5 stages of diabetic nephropathy. Stage 1 is hyperfiltration. The GFR actually increases, and that is said to be the main cause for diabetic nephropathy. Hyperfiltration mediated damage is what leads to chronic kidney disease. High glucose, osmotic effect, too much of GFR, causing damage to the glomerulus. That is hyperfiltration. Then followed by stage of apparent normalcy. Apparent normalcy. Normalcy of what? GFR. Okay. Here, glomerular filtration rate is high. Here it is becoming apparently normal. It's not normal. Actually, it was let's say initially the GFR had gone off to 150. Normally it's up to 125. So if the GFR had gone up to 150 because of hyperfiltration, because of hyperglycemia, osmotic effect, now from 150, it starts declining. So it's come back to 125, but it's actually reduced. That means the glomeruli are now beginning to malfunction. That's why the GFR is apparently normal, but it is actually reduced. And it is going to reduce further. So when it reduces further, slowly they start going into CKD. Stage 3 is when they generally develop. Forgive me, I will use these terms for now. Micro and macro albuminuria, but these are no longer accepted. So please excuse me for now. But remember, these are not accepted terminologies or preferred terminologies anymore. What the American Diabetes Association prefers instead of these is microalbuminuria. It prefers the term moderately increased. I'll mention it here like this. Okay, moderately increased albuminuria. That is the term that they prefer. Albuminuria. I'll just write it like that. Okay, and macroalbuminuria is severely increased albuminuria. So the cutoffs have not changed. Cutoffs are the same, but the terminologies which are preferred by ADA have changed. Okay, so microalbuminuria is less than 30 milligram per day. Less than 30 milligrams of albuminuria per day is known as microalbuminuria, previously known as microalbuminuria, now is known as moderately increased albuminuria, albumin excretion. Okay, it's called albuminuria or albumin excretion actually. Whereas 30 to 300, I'm sorry, what did I say? Less than 30 is normal. Less than 30 is normal. I'm sorry about that. Less than 30 is normal. 30 to 300 is microalbuminuria, also known as moderately increased albumin excretion. Beyond 300 milligram per deciliter, milligram per day is known as macroalbuminuria. Okay, severely increased albuminuria is if the person is passing more than 300 milligram per day of albumin when you check the urinary albumin level. So please don't confuse about the values. I am sorry, I caused the confusion. So moderately increased albuminuria is 30 to 300 milligram per day of albumin, whereas more than 300 milligram per day is known as severely increased albumin excretion. But the terms used are moderately and severely increased albumin excretion. And finally, yes, CKD. Okay, chronic kidney disease. This is when the GFR comes below 60. Below 60 for 3 months. 60 ml per minute per 1.73 meter square for 3 months, at least 3 months. Then it is called CKD. But if it is because of diabetes, it's called diabetic CKD. It's also called DKD. Okay, so I hope you remember aspects about pathology. The initial change is the basement membrane thickening. Then there are these nodules formed. Do you guys remember the name of the nodules on histology that is seen in diabetic nephropathy? They are PAS positive nodules which are formed in the mesangium of the glomerulus. They are called KW nodules. PS positive. That's the histology part. Right. So what are we worried about? We are worried about this progression. We want to stop this progression. So mainly the first two steps, control the blood glucose levels. Once they land up with microalbuminuria, what is preferably now known as moderately increased albumin excretion, then you can use certain agents. So where do I put this? I'll write this here. So what you can use is ACE inhibitor, ARB, or you can use finerenone. Okay, you can even use SGLT2 inhibitors. So these are agents which you can use. Okay, I mentioned finerenone, but any mineralocorticoid receptor antagonist. These can be used to prevent progression of microalbuminuria to macroalbuminuria. Please allow me to use these terms because saying moderately increased albumin excretion, 4 words is not so easy. And repeatedly using those 4 words is not so easy. That's why I'm just using one word, microalbuminuria. But the meaning is the same, 30 to 300, more than 300. Okay, so these are the agents which reduce the speed of progression from the stage 3 to stage 4. Okay. Once they have landed up in macroalbuminuria, it becomes difficult to do much. Okay. They will invariably go into CKD. Okay. There are other points about diabetic nephropathy. Nobody told me Kimmelstein-Wilson lesions. Kimmelstein-Wilson lesion. Wilson nodules, I'm sorry. These are the nodules that you see in nodular glomulosclerosis. It's called nodular glomulosclerosis. No, initially there will be just basement membrane thickening. So beyond basement membrane thickening, like any microangiopathy, that will happen. The glomerular basement membrane will thicken. Then in the mesangium, you will get PS positive nodules. That's called nodular glomulosclerosis. This is the more advanced stage of diabetic nephropathy on histology. Okay, and then you can have neuropathy. Neuropathy can be peripheral neuropathy, can be autonomic neuropathy, can be cranial neuropathy. The most common form of peripheral neuropathy is distal symmetric polyneuropathy, DSPN. Distal symmetric polyneuropathy. They'll have a glove and stocking. Mainly, it's the stocking first distribution of deficits. It will be sensory plus motor, a lot more sensory than motor, but both will be there. So initially, it will affect the most distal aspects of the lower limb. That's why stocking. Then eventually, it will affect the upper limb. So glove and stocking distribution of sensory and motor deficits be symmetrical. That is peripheral neuropathy. Autonomic neuropathy can happen. Then autonomic nerves can get affected. So wide variety of manifestations. And cranial nerves can get affected. So cranial nerves like cranial nerve number 3 can get affected. And that can lead to pupil sparing third cranial nerve palsy. Okay. There's lots actually to discuss. But then there's something called earlier what was known as Bruns-Garland syndrome. Bruns-Garland syndrome, or also known as diabetic amyotrophy, what is now known as diabetic lumbosacral plexoradiculopathy. So there's going to be asymmetric, painful proximal muscle weakness and atrophy. That is a special type of diabetic neuropathy that affects the plexus. It's a plexopathy, diabetic plexopathy. Maybe too much for you guys. Are you guys, is this all a little too much? Do you want me to cover the rest tomorrow? Or are you okay? There's still macroangiopathy and I suppose after that treatment is the only thing. Yeah. Are you guys okay to continue or do you want me to do it tomorrow. It's almost 11 o'clock. If you guys want a break, tomorrow I can finish the rest. Tomorrow, Shanti says. I understand you guys might have class tomorrow morning and all. So one lengthy session is also not very productive. Okay, Naeem is also asking for tomorrow. We'll do that only. So microangiopathic classification till here today. The rest, that means the macroangiopathic complications, and Drishti is also asking for tomorrow. Okay, and treatment aspects we'll cover tomorrow. Okay. Any doubts for today's? I'm sorry, some places I created that confusion. Microalbuminuria is between 30 to 300. 300 and above is macroalbuminuria. I hope I have not made any inadvertent mistakes. If I have made, you please then and there you correct me. Okay, when we are speaking, sometimes we don't realize you said something wrong. But if you get to know, please stop me there itself. Okay, if there are no doubts, we'll end today's session here, and I'll see you tomorrow, and we'll finish diabetes, the remaining complications, and treatment, investigation, and treatment aspects tomorrow. Okay. Thank you very much for joining. I'll see you guys tomorrow. Thank you, Yash.